Hello everyone, this is Dr. Meenakshi Gupta. Today I am going to start another topic of pharmacology, that is antimalarial drug. So what I'll be taking under this topic, the life cycle of the malarial parasite. This is number one. Then what are the various antimalarial drugs which are going to act at various phases of the life cycle of malarial parasite. Classification of antimalarial drug, important point regarding the individual antimalarial drug, then treatment of the important species Plasmodium vivax and falciparum, both chloroquine sensitive and chloroquine resistance. Then treatment of the malaria during pregnancy. Now let's get started with the life cycle of malarial parasite. Now, what is the cause of the malaria? You have seen in the previous slide the cause of the malaria, that is the Plasmodium. Okay? The cause of the malaria is the Plasmodium. Now the various species of the Plasmodium we have vivax, we have falciparum, we have ovare, and we have malaria. Now who is going to carry this parasite, or sorry, this protozoal? This is a protozoal infection or parasite, protozoal infection to the host. It is carried by female mosquito and female Anopheles mosquito. This is going to carry this protozoal infection to the human being. Now, so let's have, this is a mosquito. With the bite, it is going to inoculate the sporozoites within the blood. What it is going to inoculate? It is going to inoculate the sporozoites in the human blood. And within no time, this is going to enter where? This is going to enter in the liver. Now, what will happen in the liver? In the liver, the further development of this sporozoid will be there in the right. Either there will be further development or it will remain as such. There is a no division. It will remain as such. And once it is mature, this is a hepatic साइजोइंट, जिसमें मल्टीप्लाई किया उसको बोलते हैं हेपेटिक साइजोइंट. एंड वेयर इज दिस विच एक्ट लिव एज अ डोरमेंट, दिस इज हिप्नोजॉइड्स, इसको बोलते हैं हिप्नोजॉइड्स. वंस इट मैच्योर, देन व्हाट विल हैपन, इट विल बी released and come in the circulation. Okay, this will be released and come in the again circulation, and here it is going to infect to what? It is going to infect to the RBC. Now within the RBC, it is going to pass through the various stages: trophozoite stage, ring stage, and ultimately it will be form a mature again sciazont. After the maturity, again it will rupture, and there is a release of huge amount of merozoite in the circulation. And once this merozoite it is released, it is going to infect what? It is going to infect further different RBCs. And For few of the RBC, what will happen? Few of the RBC, they are going to change its form and form a gametes, male and female. Okay. So, and this gamete, it is taken up by the mosquito with the next bite. And further development of this gamete into the zygote will happen in the mosquito. So sexual cycle, that is there in the mosquito, whereas asexual cycle, that would be there in the human. So human, it is not a definitive host, whereas mosquito, that is a definitive host. So what I have shown here, the mosquito, it is going to inject what? It is going to inoculate the sporozoite, this one, and within no time this sporozoite, it will enter within the liver, and within the liver either it will multiply or it will stay as such, or it will be dormant. Then after the multiplication, what will happen? This mature hepatic cyzone, it will rupture and it is going to release the merozoite in the circulation, and this merozoite, it is going to infect the RBC, and further development will happen in the RBC. And once it is mature, then what will happen? There will be release of merozoites in the circulation, and which is going to infect further new RBC, and few of this will be changing its form into male and female gamete, which is taken up by the another mosquito, and there will be further development into the zygote, and this sporozoite, the further cycle will happen in the mosquito. Now this bursting, ye wala, this one, this maturation from here to here, it is a fixed. The time interval for this is a fixed. It is 48 hours for all the species except Plasmodium, malaria, where it is a 72 hours for rest of the species. So what will happen? After every 48 hours in all the species, there will be this RBC will burst, and it is going to release a huge amount of the merozoites plus various toxic material, and there will be, and this is going to cause the sign and symptom of or symptoms of the malaria. Patient will have fever with chills and rigor because of this rupture of the RBC, which happens after every 48 hours, means on the third day. Whereas in malaria, the rupture of RBC will happen after every 72 hours, that means on fourth day, and patient will have chills and rigor on every fourth day. So malaria, this fever, it is called quartan malaria, whereas rest of the fever we called is tertian malaria on every third day. Vivax, we say benign tertian malaria. Falciparum, we say it is a malignant tertian malaria. Okay. So this phase, it is responsible for the malarial fever. Now, how we are going to treat the patient? Patient comes with the sign and symptoms. Once this erythrocyte, it is going to rupture and release this. Now, with sign and symptoms, that means whatever drug we are going to give at this phase, that is going to produce the clinical cure. And this phase, we say it erythrocytic phase. Erythrocytic phase. And this phase, ये जहाँ पे आपका hepatic cyzone, this is called pre-erythrocytic. This is called pre-erythrocytic. And this hypnozoid, this is called exoerythrocytic phase. So another difference is which I have told ki RBC rupture in all the species, it is after every 48 hours except in Plasmodium malaria where RBC rupture after every 72 hours. Similarly, in Vivax and in Falciparum, what is the difference? This exoerythrocytic phase, this is not seen in Plasmodium falciparum. ठीक है, ये हमें Plasmodium falciparum में we are not going to see. And this is a gametocytic. So now we can see the 4 phases. The first phase is pre-erythrocytic. ठीक है, ये pre-erythrocytic. Then erythrocytic phase. Then exoerythrocytic phase. And then gametocytic phase. And if we are going to give the drug which is going to hit at the erythrocytic phase, that means they are going to produce the clinical cure. Where is the drug? If we are going to give the drug which is going to inhibit this pre-erythrocytic phase, which is the cause of the malaria, pre-erythrocytic phase, that is the cause of the malaria. So that is going to provide the casual prophylactic. This is going to give the casual prophylactic. Whereas if we are going to give the drug which is going to hit this exoerythrocytic phase, this is going to give us radical cure. Now what is the significance of this exoerythrocytic phase? These hypnozoids, it will remain dormant sometimes for many years. Now you have treated the patient by curing the patient by giving the erythrocytic cyzonticide. यहाँ पे आपने मेडिसिन दे दी, patient is free from the fever, free from the symptoms of the fever. Then what will happen? Because of this hypnozoids, where the parasite resides, it may become active at any time, maybe within a year, and once it gets activated, then again division will happen, and this is again patient will comes with the chills and rigor. So this is responsible, hypnozoids, they are responsible for the relapses. They are responsible for the relapses. So to cure the patient completely, so that patient should not have any relapses, you have to cure the patient clinically as well as you have to give the radical cure. Then another aim is to cut down this transmission, because this gametes, male and female gamete, they are also seen in the peripheral blood which is taken up by the mosquito. So to cut down this transmission from the human to the mosquito, we can give gametocidal drug. Okay. We can give the. So there are different stages of the parasite. At different stages, we can give different clinical cure or different treatment, and with the different like clinical cure, different drugs they are given for different things. Then another one is at this phase, before the rupture, if we give the drug before the rupture of this RBC, that is going to give the suppressive prophylaxis. This is going to give the suppressive prophylaxis. So this is the another one. This is the fourth and this is the fifth. So one way of classifying antimalarial drug is depending on its clinical use. So you have seen here the stages pre-erythrocytic, okay? The pre-erythrocytic, erythrocytic. So pre-erythrocytic, this is in the liver. Then from the liver, the hepatic scission, it rupture and it is going to infect the RBC. That is the erythrocytic. But few of the hepatic scission, they do not rupture in case of all the species except the Plasmodium falciparum. So that leads to exoerythrocytic phase. And then in the RBC, few of the forms, they are going to change their morphology and form a gametes, both male and female gametes. So, depending on the clinical use, if we are going to give the drug at pre-erythrocytic, which is a cause, it is going to give the casual prophylaxis. And what are the drugs we give? We can give a primaquine and proguanil. Similarly, for the erythrocytic, if we are going to give this one, which is with the sign and symptom, once the erythrocyte it was, patient will have chills and rigor. If you are going to give the drug, that is going to give a clinical cure, patient ठीक हो जाएगा. And the two type of drugs we have, fast acting and a slow acting. Under the fast acting, we have a chloroquine, we have a quinine also. Okay, we have a quinine also, then mefloquine, Artemis. I have written a abbreviation of this, not abbreviation, few alphabets I have used. Later on you will be seeing the full. Then artemisinin, then atovaquone, halofandrine and a lumefantrine. Whereas under the slow acting we have a sulfonamide, pyrimethamine, proguanil, tetracycline, doxycycline and a clindamycin. Whereas for the suppressive prophylaxis, this is before the rupture of the RBC. Here, if you are going to give the drug here at this suppressive prophylaxis. So this is also very commonly before the patient is on the traveling to the area and traveling to the endemic area, then what we can give to the patient for the short term prophylaxis and a long term. Short term is which is where the patient stay is for the less than 6 weeks, and long term is where the patient is going to stay for more than 6 weeks to 1 year. So for the short term we are going to use the doxycycline, and for the long term we are going to use the mefloquine. और देनी कैसे है doxycycline and mefloquine? Doxycycline we give daily. We give 100 milligram daily. So start it 2 days, and once the patient comes back and continue for another 4 weeks or continue for 1 month. Where mefloquine we give once a week. So start it 2 weeks before and again continue it for another 4 weeks once the person comes back. So this is a suppressive prophylaxis. Whereas exoerythrocytic, this is going to act on the hypnozoids. This is going to give the radical cure. And we have two drugs, primaquine and tafenoquine. Then gametocytic or gametocidal, this if we are going to give the drug at this phase, this is going to prevent the transmission. And here also for all the species we have primaquine, we have artemisinin, and for the vivax we have chloroquine and quinine. They are going to kill the gametes of vivax as well as chloroquine and quinine, right? So this is about the if you can classify this one antimalarial drug depending on its clinical use: casual prophylactic, suppressive prophylactic, clinical cure, radical cure, and prevent the transmission. इसमें सबसे important है what all we are going to use for the radical cure, which drug we are going to use, primaquine and tafenoquine, and what are we are going to use for the suppressive prophylaxis. Okay, for the short term and for the long term. Here I have told only the important drugs, and then of course the clinical cure. What are the drug we are going to use for the treatment of the malaria. Okay. Then another way of classifying this antimalarial drug is we have a two type of drug, scisonticidal and gametocidal. दो है हमारे पास sizonticidal depending on this stage of the plasmodium, sizonticidal and a gametocidal. Sizonticidal is further of two type. One is a tissue sizonticide and erythrocytic sizonticide, hepatic or tissue sizonticide and erythrocytic sizonticide. So hepatic or tissue sizonticide we have two. One is this primary pre-erythrocytic and exoerythrocytic. This is a secondary. तो ये आपका आ जाएगा. This is a primary tissue sizonticide and this is a secondary tissue sizon. Tissue and hepatic, it is one and same thing. This is another way of classifying this. So now after discussing the life cycle of the malaria, just see whether you are able to answer all these questions, so that we'll come to know whether you have understood the topic so far. So what is the cause of malaria? Plasmodium and its species already I have told. Vivax, then we have a falciparum, then we have ovale and then we have a malaria. What is the incidence of malaria in India? इसमें बहुत ज़्यादा डिटेल में जाने की ज़रूरत नहीं है. Yes, according to 2016 report, National Vector-Borne Disease Control Program, they have reported 1.06 million of cases in our country. ठीक है, whereas 216 million cases they found it globally. What are the phases of development of malarial parasite in human host? So in human host we have two phases. One is pre-erythrocytic and erythrocytic. So these are the two phases of development of malarial parasite in the human host. Which form of the parasite is responsible? It is definitely erythrocytic, that is responsible for the clinical attack. Now what is the basis of the periodicity of the clinical attack? ये वाला question. Periodicity means, like in case of all the species, the patient comes with a fever after every third day. So what is the basis of periodic? And in case of malaria, it is after 4 days. It is a maturation of that merozoites within the RBC. That time period it is fixed. So that is the basis of periodicity of the clinical attack of the malaria. Are all type of malaria they are prone to relapse? No. Okay. Plasmodium falciparum, that is not prone to relapse. And why it is so? Because here all the hepatic sizont they rupture at once. There are no hypnozoites. इसमें क्या है? There is no hypnozoites. No exoerythrocytic, no hypnozoites, no exoerythrocytic phase that is seen in Plasmodium falciparum. Is there any mean to distinguish clinically or parasitologically between the relapse and reinfection? इसका क्या मतलब है? Relapse means the person is getting the infection from the hypnozoites. ठीक है. एक्सोएरिथ्रोसिटिक फेज में क्या है? एक्सोएरिथ्रोसिटिक फेज में where the parasite it was dormant and it gets activated, it gets multiply and there is a rupture. So this is from the hypnozoites or exoerythrocytic. अगर पेशेंट को इससे हुआ मलेरिया and patient has got the infection with the new bite, so can we distinguish it clinically or parasitologically? हमें कैसे पता चलेगा कि this is relapse or this is a reinfection? So we cannot distinguish. Clinically उसको same sign and symptom आएंगे whether it is because of the hypnozoites relapse से या new bite से. And parasitologically, even if you are going to see the slide, you won't be able to make out whether it is because of the relapse or reinfection. Now coming to the few of the important MCQ. Tissue sizonticide which prevent relapse of Vivax malaria. So tissue or hepatic. Already I have told tissue and hepatic sizonticide which prevent the relapse. So tissue wala kya hai? This is in the liver. ठीक है. So in the liver, the few they multiply and few they remain dormant. This sporozoites, and this is the what which is going to cause the relapse. And what are the drug we are going to give? It is a primaquine. So that means we are asking the drug which can give a radical cure, मतलब उसकी जड़ से बीमारी खत्म कर दे. So that is we have only two drug. One is a primaquine and another one is a tafenoquine. Then radical cure, it is required for the malaria. Radical cure, again same thing, which is going to target this hypnozoites. So this is seen in almost all except in Plasmodium falciparum. So just see the choices here. यहाँ पे Plasmodium falciparum तो ये नहीं है, इसमें भी है, ये नहीं है. So here you won't be seeing the Plasmodium falciparum. So radical cure it is required. हाँ इसमें ये है कि Vivex वाला right है, but we have another one also falciparum. इसलिए इसको tick नहीं करना. A is a wrong choice, B is a wrong choice. Correct choice is it is a C. Now, drug of choice for exoerythrocytic stage. Again, the same question, like the same thing can be asked in a different way. Exoerythrocytic phase, it is again that we are talking about the hypnozoites. We are talking about the stage which is going to cause the relapse. Okay? So, here again the drug we have a two, primaquine and tafenoquine. देन द इन्फेक्टिव फॉर्म ऑफ मलेरियल पैरासाइट जो सबसे पहले मॉस्किटो बाइट करती है ह्यूमंस को, इट इज गोइंग टू इनोकुलेट द स्पोरोजॉइड्स. ठीक है. देन कीमोप्रोफिलैक्सिस इन एन इंग्लिश मैन विजिटिंग क्लोरोक्विनीन एंड मेफ्लोक्विनीन resistant malarial region is done with. So chemoprophylaxis, we are talking about the suppressive prophylaxis. We are not talking about the pre-erythrocytic or okay. So suppressive prophylaxis I have already told, the short term and the long term. So for the short term we give the doxycycline and for the long term we give the mefloquine. But this person is visiting chloroquine and mefloquine resistant. So mefloquine to यहाँ पे नहीं देनी. So what we can give? We choose doxycycline. Okay. So next, so far we have covered the life cycle of the Plasmodium and the various drugs which are acting at the different phases of the life cycle of the Plasmodium. Next one is the classification of the antimalarial drug. So classification, ठीक है, based on clinical cure, ये मैंने पहले बता दिया. Based on the clinical cure we have the casual prophylactics. दो आपके पास prophylactics है, casual prophylactics and suppressive prophylactics. Two you have a cure, we have a clinical cure, we have a radical cure, and the third one is a gametocidal. And the based on affected plasmodial state we have a scisonticidal drug and gametocidal drug. Okay. So scisonticidal drug we have a hepatic or tissue scisonticide and we have a erythrocytic scisonticide. So hepatic में आपके further we have a pre-erythrocytic and exoerythrocytic. This is a primary and this is a secondary. Then based on the chemical structure, the classification, this is the one usually which students they write. The depending on the chemical structure, how we classify this, I have taken from the Tripathi, KD Tripathi, one of the standard textbook of pharmacology. So this is according to chemical classification of the antimalarial drug. We have a 4 aminoquinolone and then we have a 8 aminoquinolones. ठीक है. 4 amino में we have a chloroquine, amodiaquine and pipraquine. 8 amino में we have a primaquine and tafenoquine. Then we have a quinoline methanol, mefloquine, cinchona alkaloid quinine quinidine, biguanide proguanil, and then diaminopyrimidine pyrimethamine. Then among the sulfonamides we have sulfadoxine, sulfamethopyrazine and dapsone. Antibiotic we have a doxycycline, clindamycin. Then we have a artemisinin derivative, उसमें artesunate, artemether, arteether, इतने याद हो, dihydroartemisinin and arteriolane. Then amino alcohol, lumefantrine and halofentrine. Then we have a naphthoquinone, atovaquinone. Then we have a pyronaridine. So this is the drug. Okay? Naphthyridine or pyronaridine, this is the drug. So in the next video I will be starting with the individual drug, the important point related with the chloroquine. So that's all for today's video. If you have any query related with today's video, you can ask your query in the comment section. Thank you for watching my video.